Okay, we're going to go forward now with the lunch and learn session. And our first speaker is Elias Klemperer. And Eli is an assistant professor at the University of Vermont in the Department of Psychiatry and Psychological Science. As an investigator with the VCBH, Dr. Klemperer's research primarily develops clinical and regulatory interventions to reduce harm from tobacco use, with a particular focus on nicotine reduction and dual users of cigarettes and e-cigarettes. In addition, Dr. Klemperer has a growing program of research on the treatment of opioid use disorder among people who are incarcerated or recently released from incarceration in rural communities. Eli?
Thanks, Steve. Really excited to get to share with you some research other than tobacco research today, despite the fact that this is focused on tobacco, this conference. So today's presentation will be on implementing medication for opioid use disorder and the impact of COVID-19 on treatment engagement after release and post-release overdose in Vermont's statewide correctional system. It's my funding information, and I have nothing to disclose. So as many of you are likely aware, the opioid epidemic continues to have devastating effects across the United States. And here in Vermont, we're no exception, with approximately 42 deaths per 100,000 people. Overdose is a particularly big problem when it comes to people who are incarcerated. So it's a leading cause of death upon release from incarceration in the US. And estimates range, depending on the region in the US, from anywhere from an increase of a 10-fold to up to 100-fold increase in the likelihood of overdose within that first 2-week period after release from incarceration compared to age-matched controls. So regardless of where you look, whichever correctional system it is, the take-home is that that period following release from incarceration is an incredibly vulnerable time period with a high rate of opioid overdose. Now, fortunately, we have FDA-approved effective medications, or medication for opioid use disorder, including buprenorphine, known as Suboxone or Subutex, methadone, and naltrexone. Unfortunately, most people who are incarcerated in the United States don't have access to these life-saving medications. This differs by system, differs by state, but largely due to systematic principles or the way that the systems are run. Here in Vermont, we are somewhat of a progressive state. We passed Vermont Act 176 in 2018 to become the second state in the country to offer all FDA-approved medications for opioid use disorder to all people who are incarcerated who meet medical necessity. This was enacted in July of, this was passed in July of this was enacted in July of 2018. And I was lucky enough to get to do the evaluation of this implementation. And we delivered our report to the Vermont legislature in January of 2022. And that's the foundation for the data I'll present to you today. But another big thing happened during this time period, which was COVID-19, which affected everything, including those who are incarcerated. A number of different things changed that you can see here on the screen. But of note, we had a precipitous decline in the incarcerated population in the United States, largely due to the rapid release of nonviolent people who were arrested for nonviolent crimes. So there's thought that this likely had some impact on the treatment of opioid use disorder for people who are incarcerated and being released from incarceration in our state. So we ended with this timeline here, where we see we were able to access administrative data before the implementation of medication for opioid use disorder, after the implementation of medication for opioid use disorder, and then after the onset of COVID-19. So we ended with 3 discrete time periods that we could start to just run some very basic models on to assess change pre-post during those 3 time periods. So our first aim was really to assess medication for opioid use disorder, utilization, and characteristics of treatment engagement among people who are incarcerated in our state. And for this, we accessed Vermont Department of Corrections administrative data, and we're lucky enough to be able to analyze those. So here's what our population looked like. We included every individual who was incarcerated for one or more nights during that 5-year time period. So the sample during each of our chunks of time, period A is before MOUD was available. Period B is after MOUD was available, but before COVID-19. Period C is during COVID-19 and after MOUD was available. I just want to draw your attention to the difference in sample size, reflecting that reduction in incarcerated population in period C. Otherwise, the demographic were comparable. So right off the bat, we looked at the percent of the incarcerated population that received any MOUD while they were incarcerated. Period A there, you can see almost nobody received medication for opioid use disorder. Those that did were part of pilot programs in the state of Vermont. In period B, after MOUD implementation, demonstrating that this was effectively implemented, we had around 34% of individuals who were incarcerated for one or more nights who were prescribed one form of MOUD. This decreased during the pandemic to about 27%. Now, you note these are stacked bars here. The blue represents buprenorphine in the form of Subutex. Red is methadone, and green is naltrexone. So the vast majority of people who were prescribed an MOUD received Subutex or buprenorphine while incarcerated. So digging a little deeper into these data, we wanted to look at the difference between those who initiated MOUD upon incarceration versus those who continued. This is important for a couple of reasons, but one is because those who initiated MOUD upon incarceration were deemed to have medical necessity for that, or an opioid use disorder, but they had not been receiving that prior to incarceration. So it represents a population that was newly initiated onto these life-saving medications, or a window of opportunity to get on these medications. So right off the bat, just draw your attention to the small n in period A. Again, this was before MOUD was widely available in our state. But in periods B and C, what you can see is over half of the people who received a prescription for MOUD while incarcerated newly initiated that medication. Although that did decrease over time, along with pre versus post onset of COVID-19. So then let's look at discontinuation. So I've talked to you about how these medications have life-saving potential, and this is especially the case after release from incarceration, where illicit opioids are widely available. But what we found was approximately 16% of people who were prescribed MOUD during that year after implementation discontinued their medication prior to release, and that decreased by half after the onset of COVID-19. All the same, we're seeing some discontinuation prior to release from incarceration, which is a little counterintuitive given how important these medications are. So we looked at reasons for discontinuation, and by far and above, the most common reason in both time periods where MOUD was available for people who were incarcerated was the DOC's report of diversion. You can see the red bar represents period B before COVID-19, green is after the onset of COVID-19. And the most common reasons, again, were diversion, and then you can see the other reasons listed there. I want to draw your attention to the large amount of missing data in period B, right after the right after the implementation of MOUD. So it's not really clear how these reasons changed over time. Depending on how that missing data is distributed across period B, that could affect some interpretation. So I think the real take home from this is that diversion was the most common reason for those subset of individuals who discontinued prior to release from incarceration. So for our aim 2, we wanted to follow these folks out into the community after release, again, during that very vulnerable time period immediately following release from incarceration. To do this, we linked the DOC data with Medicaid claims data, partnering with Vermont Blueprint for Health. To start with, and I think one of the more important findings from this whole presentation is a continuation of medication for opioid use disorder during that vulnerable period after release from incarceration. And so on the left here, sorry, let me back up a sec. This is the important piece to consider here is these are release episodes among people who had an OUD diagnosis. So what that means is, in order to be in the denominator here, you had to have a Medicaid claim indicating you had an opioid use disorder and you had to be released from incarceration. What we can see is 33.9% of releases before MOUD was implemented in the Vermont Department of Corrections resulted in MOUD in the community within 30 days after release. That increased significantly after MOUD was implemented in correctional facilities in our state to 41%, and then decreased again with the onset of COVID-19, which is consistent with reports across the country in other correctional systems, though they don't have MOUD in many other correctional systems in the system. Those receiving MOUD in the community also decreased after release in other states. So then I want to drill in on this a little bit more. And now what you're looking at is only those individuals who actually received a prescription for MOUD while incarcerated. So that red bar there represents 47.8% of people who received an MOUD prescription while incarcerated, followed up with that prescription within 30 days after release from incarceration. And that had a numerical but not significant decrease to 41.3% during the year following COVID-19. So this is important. I think this is a glass half full, glass half empty kind of situation. This is far better than many other states who don't have MOUD available in correctional facilities, but we can also do a lot better. Half of the people released from incarceration who are receiving these life-saving medications don't continue them following up in the community. So finally, I want to talk to you about fatal and non-fatal overdoses during these same 3 time periods. To do this, we linked 3 data sets, Vermont Department of Corrections, administrative data, Blueprint for Health, Medicaid claims, and Vermont Department of Health death data. And so this is opioid-related overdose after release from incarceration. On the left, that's non-fatal opioid-related overdoses within 30 days after release. And what you can see is we start with small base rates. Note the y-axis is only up to 5%, but that did significantly decrease in period B with the implementation of MOUD among people who were incarcerated. And then non-fatal overdoses, like we saw across the country, had an over 2-fold increase among people who were released from incarceration with the onset of COVID-19. The story is a little better when we look at fatal overdoses. That's those cluster of bars on the far right. In period A, before MOUD was available among people who are incarcerated, we had 1.1% people who were incarcerated, releases from incarcerated ending in a fatal overdose during the following year. And that decreased to less than 10 deaths and held to less than 10 deaths during the pandemic. Those data are censored to protect confidentiality. So I just presented quite a bit of data in just a few minutes here. So I want to summarize what I think are the big take-home points here. And if anyone's interested in this, I'd be happy to send the full report as well. So with Act 176, and this is the act that implemented MOUD in correctional facilities in our state, which again is the second state to do so, we saw a significant increase in utilization while incarcerated, an increase in use of this life-saving medication after release, decrease in non-fatal, and decrease in fatal overdoses after release. And this is important. This is a real-world demonstration of what we've seen in a number of randomized clinical trials now. And so it's very nice to see this at a statewide level, also replicating what was found in Rhode Island, the first state to implement MOUD statewide. However, with the onset of COVID-19, we see somewhat of a mitigation of these benefits here. Decrease in MOUD while incarcerated, decrease in MOUD after release, and an increase in non-fatal overdoses. So there's still work to be done, with a particular focus, I think, on increasing the continuation of MOUD after release from incarceration, given what we know about that high-risk time period. We already have these folks on life-saving medications, so the challenge is to bridge that back into the community as people are released. So with that, I will end. And before I do, I want to thank the phenomenal team that made this all possible. This was a big effort across a lot of different groups here. So at UVM, you can see the co-authors here, and at the Vermont Department of Corrections, Blueprint for Health, as well as a colleague at the University of Massachusetts. Thanks. Questions?
Thanks, Eli. Very, very good talk. So our next speaker in the series is Dr. Kelly Peck. Kelly is the Director of Clinical Operations for the UVM Center on Rural Addiction. He's an assistant professor with joint appointments in the departments of psychiatry and psychological science at the University of Vermont. He received his PhD in clinical psychology from the University of Mississippi. His primary research and clinical interests are twofold. First, he has conducted research focused on the development and evaluation of novel treatments for opioid use disorder. Second, he has worked extensively to address co-occurring post-traumatic stress disorder in individuals with substance use disorders, particularly around the delivery and evaluation of cognitive behavioral treatments for PTSD. Dr. Peck is currently conducting a randomized clinical trial aimed at developing and evaluating a novel prolonged exposure therapy protocol to improve PTSD therapy or extended exposure therapy attendance and reducing symptom severity among individuals with co-occurring PTSD and OUD. Kelly.
Thanks for sticking around during lunch. I'm excited to share a little bit about our work at the UVM Center on Rural Addiction. And the focus of this presentation is our efforts to disseminate evidence-based interventions for treating opioid use disorder in rural communities. So as many of you may be familiar, we're in the midst of an opioid epidemic in the United States. It's a severe public health crisis. So these figures here on my left, your right, show that overdose deaths have continued to increase with a particularly sharp rise since 2020 in the COVID-19 pandemic. So in 2021 alone, there were over 100,000 drug overdose deaths in that year alone. And then opioid-related overdose deaths have also shown a similar sharp increase over the past several years with sort of these converging pandemics, the opioid crisis and the COVID-19 pandemic. And even though a lot of attention has been paid to overdose deaths among males, we see that overdose deaths related to opioids are also rising precipitously among women. These overdoses and health costs, it's not just a personal cost. You also see financial costs associated with the ongoing crisis. And recent estimates indicate that the opioid crisis costs over $1 trillion each year. We know that drug overdose deaths may be a particular problem in rural areas. So as I sort of mentioned before, from over the past 20 years, drug overdose deaths have increased from 4 per 100,000 to 19.6 per 100,000 in rural counties. So we see sharp increases in both rural and urban counties. Although if you look across the country generally, you see higher overdose rates in urban counties, there are several states in which drug overdose deaths were higher in rural counties. Those states include California, Connecticut, North Carolina, and the state that we're now, Vermont, and as well as Virginia. So in those states, you see higher rates of overdose deaths in these rural counties versus non-rural counties. We also know that compared to their urban counterparts, rural individuals with opioid use disorder have higher prevalence of prior overdoses. They have poor knowledge about opioid overdose and the risk factors for overdose. And they also have poor knowledge of how to respond to an opioid overdose. So there's significant vulnerabilities in this population. In response to the crisis, we have some harm reduction and treatment techniques and tools at our disposal. One of those being test strips. So fentanyl and xylazine test strips are available. You can use these tests to check your drug supply for the presence of these adulterants that place people at higher risk for overdose. The fentanyl test strips have been available in the United States since 2011. They're intended for testing urine, but they can be used off-label to test drug samples diluted in water for the presence of fentanyl. Pretty good sensitivity and specificity. Although availability of these products can vary across state, as state laws, depending on the state that you're in, can sort of classify these test strips as drug paraphernalia, whereas in other states, like in Vermont, they're legal harm reduction supplies. More recently, xylazine test strips have become available. So xylazine is a fairly new adulterant in the opioid and other drug supply. These test strips became available just this spring. They're intended for testing a drug sample in diluted water, good sensitivity and specificity, although there is some cross-reactivity with lidocaine, which is commonly used to cut the cocaine supply. There are also, in addition to test strips, so these harm reduction approaches, we also have effective approaches to prevent overdose and to counter adverse effects. So naloxone is available to reverse an opioid overdose. And then, another strategy that's very important is increasing the availability of effective opioid use disorder treatments, so particularly agonist maintenance treatment. So agonist medications for opioid use disorder, when I say that, I'm specifically referring to buprenorphine and methadone. They're the most effective treatments that we have for opioid use disorder. These medications are longer acting opioids. They're administered daily. They're associated with less euphoric effects. They're safer compared to your acute or other opioids, and associated with reduced withdrawal and cravings, lower illicit opioid use, reduced risk of behaviors associated with other negative health outcomes and disease. And then they're more effective than non-pharmacological treatment approaches for keeping people in treatment, reducing illicit opioid use, and then reducing all cause opioid-related mortality. So long-term treatment is recommended for these medications, and it's associated with better outcomes. The longer that you can keep these people on these medications, typically the better the outcomes are. And so as I mentioned, the two most commonly used and most efficacious treatments are methadone and buprenorphine. So methadone is a long-acting full opioid agonist that binds to and occupies the same receptors as any other opioid. It prevents or reverses withdrawal symptoms and also reduces cravings for opioids. Limitations for this medication is it may be the most heavily regulated medication in the United States. There are strict rules for dispensing. There are also, because it is a full agonist, it does produce and maintain dependence on opioids. It is a full agonist, and so there is a risk of overdose death for individuals who are opioid naive. And then buprenorphine is a partial opioid agonist. It's associated with less euphoria and sedation versus a full agonist like methadone. It's associated with less craving and less illicit opioid use versus placebo. And it's similarly effective as moderate doses of methadone for keeping people in treatment, reducing illicit opioid use and illicit opioid craving. And it's available in general medical settings, so it's easier to access in many settings without the same regulations that you have with methadone. And it doesn't require daily dosing or daily observed dosing, excuse me. So despite the efficacy of these medications, we have a pretty substantial body of literature to indicate that methadone and buprenorphine work. Only 22%, so less than a quarter of Americans with opioid use disorder have received this treatment within the past year. So we have a lot of people with opioid use disorder who are not receiving these treatments. So we know that office-based buprenorphine or the idea is that it is compatible with rural and sparsely populated areas, because you don't have the same regulations that you do with methadone. You don't have to go in for daily dosing. Treatment often remains underutilized, especially in rural areas where half of rural counties lack a single buprenorphine provider. And then the providers who are licensed to provide buprenorphine they tend to carry fewer patients than they're permitted. So this medication is really underutilized. So innovative approaches are urgently needed to expand access to these evidence-based treatments for opioid use disorder, specifically in rural areas. So in September of 2019, 3 rural centers of excellence on substance use disorders were established with support from the Health Resources and Services Administration and their rural communities opioid response program. So the mission of this program was to support rural providers and their staff in their efforts to treat patients with substance use disorders, with an overarching aim of expanding addiction treatment capacity in HRSA designated rural counties. So the University of Vermont Center on Rural Addictions mission has been to provide consultation, resources, education, technical assistance, and evidence-based practices to healthcare providers and their staff in rural communities. So our focus has been Vermont, New Hampshire, Maine, and Northern New York. But then over the past 4 years, we've really expanded to have a national reach. So again, our objectives are to leverage the expertise that we have here at UVM, both clinically and our research expertise, and evidence-based practices for treating opioid use disorder, as well as other substance use disorders, to both identify real-time needs of our rural communities, and so to identify the real-time needs in our rural communities, and to also identify science-supported methods for effectively addressing current and future addiction treatment needs. So our goal is to identify what's going on in the community, what may happen in these trends, rapidly evolving crisis, and then to be able to deliver ongoing technical assistance as well as workforce training to support the effective use of best practices for assessing and treating rural patients. So once we sort of get a sense of what those needs are, can we deliver support and education and training so that people can better respond to those needs? And then we also want to disseminate education and resources on evidence-based treatment in the prevention so both treatment and prevention efforts to rural providers and policymakers. So those are our goals. Our center is divided into 4 cores. So our surveillance and evaluation core has really been focused on that first goal of identification. So we've conducted several baseline needs assessments to identify the real-time needs and barriers in rural communities. We've also assisted providers and practices with establishing and improving their data systems, and then monitoring drug use patterns in rural communities, what's going on in these specific communities. We have our best practices core, which is really focused on the delivery piece. So that is providing in-person and remote technical assistance on how to implement these evidence-based practices within a specific practice. And then we have hardware, software, and resources and training that we can provide in new and expanded models of care and delivery. Our third core is related to education and outreach. So that is what it sounds like. We have a community rounds webinar series that happens monthly. We have experts, content experts who come and speak on specific topics that are relevant to our providers in rural communities. We have a quarterly newsletter that goes out, as well as research spotlights, where we try to highlight peer-reviewed publications that are relevant to our partners, as well as we have a growing resource library and online learning collaborative. And then finally, our clinical and translational core. We try to provide peer counseling and consultation. So this is more mentoring-based training and evidence-based treatment and patient-centered care coordination. So we have providers here at UVM who are experts in providing these interventions. And so we try to pair these experts with providers in these rural communities so they can get more one-on-one individualized mentoring on how to deliver these interventions. We have a clinical and translational scholarship program where we will bring in the staff and providers at these from these rural locations to spend 2 days with us and to really do an intensive training over the course of 2 days with our staff on how to, what are the needs that you have, and then how can we take some of these tools and resources that we have available so that you can implement them within your own practice. And then we have our clinician office hours program. where we have our several clinicians who are available at pre-specified times. People can sign up and seek some mentoring and feedback on how to deal with maybe a particularly complex case or cases that people are seeing more frequently within their practice. So just to provide a quick overview of some of the resources that we have available through UVM Cora, we have overdose prevention and management, which includes both Narcan test strips. We recently placed the first Narcan vending machine in the state of Vermont down in Johnson. We were all very excited about that, just trying to make these harm reduction resources more readily available. Providing mentoring, counseling, education around providing pharmacotherapy, including buprenorphine and methadone. We have technology-assisted components like a meta wheel to help actually be able to implement these medications within practice. Medication safekeeping, so lock boxes, lock bags. These doTERRA bags are pretty cool. It's a safe way for drug disposal. And then biochemical monitoring if providers are interested in implementing that within their practice. And all of these resources are provided free of charge through UVM Cora. We're also interested in expanding system capacity. So like I mentioned, many rural counties don't have a single buprenorphine provider, and the providers that are there are not taking as many patients as they are permitted. So trying to expand capacity, giving people the tools and resources that they need so that they can take on more patients within their practice. We also have a team that's has expertise in addressing co-occurring problems, whether that be PTSD, other substance use, tobacco use, smoking, providing patient and family-centered care. And then we have a battery of assessments that we can provide and provide training in as well. And then education around infectious diseases like HIV and hepatitis C. So that's sort of just, these are snapshots of the resources that we have available to provide to our rural partners. So just to provide a snapshot, like I said, this center was funded in 2019, so we just recently wrapped up year 4. So this is what we've accomplished within our first 4 years of existence. So to date, UVM Cora, and these numbers are probably dated. Like I think these numbers are higher now than they were when I put this slide together, or when our team put this slide together. I didn't make the slide. But the Cora has supported over 32,000 rural health providers in all 50 states. So like I said, we started off with a goal of focusing on New Hampshire, Vermont, Maine, and Northern New York. And then we've really grown to have a national reach. We've had over almost 7,000 community rounds participants. So that's our monthly webinar. Those attendees have come from 46 states. We provide CME credits for attending that webinar. Our clinician office hours is established to connect rural providers to individualized expert support. And then we've also held 3 of our scholarship programs. Those are events where we bring in practices to our location to provide 2 days of intensive training. So we've had 180 CME credits claimed from those 3 events. We now have more than 30 tools tailored for rural use. So that includes our research spotlights, data reports, which is the summary of our brief needs assessments that we've conducted, data briefs, resource guides, user guides. We have a growing portfolio of these educational resources. Over 100 peer-reviewed publications have been published since we started in 2019. And then our technical assistance work is, I think, really impressive. So over 950 technical assistance interactions in 33 states over the past 4 years. So that is where our best practices team meets with the practice, learns about their needs, and then tries to match our portfolio of resources with the needs that they report. As a result of those technical assistance meetings, we've disseminated over 350,000 supplies. So that could be harm reduction, tobacco cessation, medication safety resources, you name it. I suspect that number is well over 400,000 at this point. And then we've also developed a robust platform for dissemination. So our listserv has over 2,000 subscribers. We have close to 3,000 website visitors per month from 48 states. And we've presented at over 450 conferences over the past 4 years. Our community rounds workshop series, we had Matt Carpenter present back in August. We try to have presentations from content experts on critical topics in rural areas. CME credits are available. So if you're interested in that, there's a page about that on our website that has recently been renewed, remodeled, and looks really good, I think. And then our educational resources are available to anyone. These are free. You can click and download them off our website. So we have user guides, how to use specific tools and resources, resource guides. So if you're looking for the basics on medications for opioid use disorder, we have a one-page document that sort of takes you to all the seminal articles and guides on that particular topic. Research spotlights that try to sort of distill emerging research into sort of a bite-sized digestible chunk. If you don't have time to read the full 12-page article, we try to distill it down a bit. So that's just sort of a snapshot of what we do at Cora. We have an incredible team at UVM Cora. I see Lauren Eicher back in the back. Eleanor Broy is back at the table out in the hallway. They've been involved in the dissemination of these materials as well as putting on our educational events and have done just an incredible job. We have a really dedicated group who work with us and who have, I think, really done some really meaningful work. And then it's also important to acknowledge the other two centers of rural excellence, rural centers of excellence. We have one at the University of Rochester who's focused on focus on stigma, and then also reducing morbidity and mortality related to substance use disorder. And then the Fletcher Group, who's really focused on the expansion of housing capacity and quality, recovery housing capacity and quality. So we partner with them very closely. So thanks for your attention. If you're interested in UVM Cora or would like to learn more about what we do, or maybe something could be helpful for you in your practice, let us know. We're happy to talk. Thanks.
All right, so thanks for that excellent lecture, Kelly. And so now we're going to have our third and final speaker for this session. I'm looking at the time. I don't think we're really going to have the time for a Q&A session or component to this session, but I'm sure any of the speakers would be happy to respond if you emailed them. So our final speaker is Dr. Tyler Erath, who is a postdoctoral fellow in the Vermont Center on Behavior and Health. His research is broadly focused on behavioral health, substance use disorders, and health disparities. A central tenet that connects his research, past, present, and future, is to integrate evidence-based practices into real-world community settings. Dr. Erath's current projects include collaborative work with a local syringe service program on substance use and treatment interest among individuals who inject drugs, and behavioral economic research examining the substitutability of alternative tobacco products among individuals who smoke menthol cigarettes. Tyler?
Can you hear me okay? So today I'm going to be discussing a little bit about the ongoing overdose epidemic and then how it relates to the implementation of incentive-based interventions for stimulant use disorder. So as Kelly and Eli have so eloquently described some of the work around opioid use disorder, I'm really going to be emphasizing stimulant use disorder here. So the current overdose and really the broader public health crisis involving illicit drug use is often referred to today. You'll often hear it as an opioid or a fentanyl crisis. And clearly there really is extensive data on the profound damage from opioid use disorder over the last couple of decades, and then specifically by fentanyl over the last handful of years. However, there is also an array of data suggesting that there is more to the current crisis than opioids and fentanyl. So often what's categorized as this fourth wave of the overdose epidemic. It is easy to see the impact of fentanyl as the red line here in the graph depicts. However, overdose rates associated with psychomotor stimulants, so this includes cocaine and methamphetamine, those have also dramatically increased over the last couple of years, with stimulants also playing really a major role in U.S. overdose deaths as well. And so the data for stimulants is depicted by the blue line in the figure here, and you see it's increasing at a very similar rate to that of opioids and fentanyl. And so what these data show is that just between a little snapshot of 2015 and 2019, overdose deaths involving stimulants increased by over 180%. So prior to 2007, cocaine was really the most commonly drug involved in overdose deaths. And then there was a shift. So from about 2007 to 2013, this moved to prescription opioids, followed by heroin in 2014. Then fentanyl and its fentanyl analogs took over in 2016. And now what we're really seeing is this situation where there's polysubstance use that's occurring mainly in combinations of fentanyl and different sorts of stimulants. And so relatedly, Friedman and Schover published this paper last year looking at polysubstance use in overdose deaths from, in this case, 2010 to 2021, so a little over a decade. And what they were looking at was differences by states, year, and then some other demographics. So this data comes from the CDC's Wonder database. And so here the researchers were looking at the percentage of overdose deaths that involved either fentanyl, stimulants, a combination of fentanyl and stimulants, and then neither stimulants nor fentanyl. And so again, these data for 2010 to 2021. And so what they were measuring was the most co-involved substance at both the state level and then across the study period. So this graph depicts here overdose deaths that are set up like I was describing. So what we have is each of these blocks representing those groups. So down there in the bottom is fentanyl only. Purple is fentanyl and stimulants. The red is stimulants only. And then neither fentanyl nor stimulants is, I guess, showing up as a neutral color. And so what they found was that the percentage of overdose deaths that involved both fentanyl and stimulants, this number grew an astounding 60-fold. So it was just down at about 0.6% in 2010. And now accounts for over 30 or about 32% in 2021. And so, yeah, those data are depicted in the purple bars. The percentage of overdose deaths involving fentanyl without stimulants, so this rose from about 7% to about 35.7% in 2020. And then it declined a little bit in 2021. And so those data are depicted in the blue bars. And then the proportion, also of interest here too, is the percentage of proportion of deaths with stimulants and no fentanyl, so only stimulants. And that's depicted with the red bars. This remained relatively stable over time, so it was about 15% in 2010. It moved up to about 18% in 2021. However, it's important to note that when we're talking about these proportions, what's been occurring across the decade is these exacerbations and really high overdose rates that are happening. So what this really means, even though these numbers are staying proportionally about the same, is that when it comes to 2021, overdose deaths that involve stimulants without opioids was detected in about a little over 19,000 deaths. So also a really significant issue. And then, so their results also suggested some interesting regional differences in the overdose death data by looking at the specific type of stimulant that's being used alongside fentanyl. And so the data here depicted on the screen are for the most co-involved drug and overdose deaths by state and region. So in 2010, fentanyl was the most co-involved with prescription opioids, followed by alcohol and then benzodiazepines. And then we start to see the earliest shift in the pattern of use in the Northeast. So each of these are broken down by sort of a geographic region and then by states listed here as well. And so again, these different substances are listed. So for our purposes, what we're seeing here in the Northeast was over time, there was some, earlier on in 2010, there were some differences, but then as we see by 2021, the predominance was occurring where the most co-involved stimulant was cocaine in a couple states with methamphetamine, which is showing up as that light red. So then in the West in 2010, the most co-involved substances were again prescription opioids, benzodiazepines, and alcohol. And then that we see a commonality in that methamphetamine has taken over as the most common. And then similar situation occurring in the Midwest and the South, in that we're seeing a lot of methamphetamine, but also some cocaine as the most common co-occurring substance as well. And then here, what these data depict are the percent of overdose deaths that also include stimulants. So here it's broken down by state and then by year. So each of the different years is a different circle, with 2021 being the most recent. Essentially, what this figure suggests is that, as you can really see, it's pretty easy to see, there's been a significant increase in the proportion of deaths involving stimulants just in that time period from 2015 to 2021. There wasn't really a case where it hasn't gone up. And so some of the highest states were those like Alaska, Hawaii, West Virginia, states that you might expect and have been talked about a little bit. Vermont came in at number 9, so not too far down the list here when we're talking about different states. So taken together, these results suggest that overdose deaths involving both stimulants and fentanyl grew a staggering 60-fold just in a little over a decade. And then what's interesting is that the most widely used stimulant does continue to vary by geographic region, with cocaine being the most common here in the Northeast, and then methamphetamine really being a prominent stimulant that's being used alongside fentanyl pretty much everywhere else in the US. And what these data also point to is a really pressing need to identify effective treatments for stimulant use disorder, and then for those to be readily available. So with respect to treatment, currently the most effective intervention for stimulant use disorder, has been described by a few of our other presenters, is contingency management, which is an intervention where participants can earn financial incentives or other sorts of tangible rewards for objective evidence, in this case of abstinence from drug use, so for abstinence of stimulant use. And there are a couple of classes of pharmacotherapies that are being looked at as potential medications similar to medications for opioid use disorder. But at present, there are no FDA-approved medications for the treatment of stimulant use disorders. And the most efficacious treatment we do have is contingency management. So in a recent meta-analysis on treatment for cocaine use disorder, Bensley and colleagues, they looked at 157 studies, about 16,000 participants. And what they found was that contingency management was associated with the highest reductions in cocaine use. Then in another recent, somewhat recent systematic review, Brown and DeFulio were looking at the results of studies on contingency management here, particularly for methamphetamine use. And so the outcomes they were looking at were things like drug abstinence, treatment retention, treatment attendance, sexual risk behavior, mood, and then a couple of other predictors. And what they found was that contingency management resulted in reductions in methamphetamine use in 26 of those 27 studies. In addition, it was also associated with other positive outcomes, so longer retention in treatment, higher treatment attendance, less risky sexual behavior, and increases in positive affect. Thus, at this point, the evidence for contingency management for the treatment of stimulant use disorder is really well supported by, at this point, numerous meta-analyses over 3 decades of randomized clinical trials. However, as Dr. Higgins mentioned just a little while ago, it's only been implemented in real-world settings quite minimally, and really just within the U.S. Department of Veterans Affairs. And this is due in part to numerous challenges that have inhibited its widespread adoption. So for example, some of those are things that are listed here on the slide. So this includes resistance that still is out there about the use of incentives to promote positive behavior change in this area. Another is, and a really important one, is that there is some limits on the use of federal funds for contingency management as it currently stands. And then along with that, there is some confusion around the use of CM and how it relates to other sorts of issues like anti-kickbacks and inducement regulations, which is for another talk. And then another challenge relates to the absence of evidence-based training and implementation to get this into real-world community settings. And then finally, another challenge is creating evidence-based CM protocols, which does involve deciding on numerous parameters, and to date, at least, no well-established guidelines or protocol that you can point to as the protocol that's an evidence-based one out there. So a big question that I was kind of getting at just a second ago was expanding the use of CM. Where does this money come from, and where can we find money to do so? So at present, there is a cap of $75 on the use of incentives per person per year at the HHS policy level. And so this is way below empirically supported amounts for efficacious contingency management. And so many of the published protocols have earnings of over $1,000, and this is across decades. So that number can fluctuate a little bit as you think about it in 2023 terms. That $1,000 is about over a 12 to 16 week period. And then there's also this issue that comes along with it as incentives as a form of taxable income. And so currently $599 is the maximum amount that someone can earn as an incentive before the IRS would consider this taxable income, which therefore then requires someone being provided with a 1099. So for example, in the California statewide initiative that Dr. Higgins talked about just a little bit ago, $599 is the maximum number of incentive that someone can earn across a 6-month treatment period. While there is an ongoing push by numerous individuals to change this $75 limit with HHS, there are also various different strategies that can be used to go about trying to finance contingency management. And so one of those is to advocate for the use of opioid settlement funds to be applied to contingency management. And so, for example, just here in the state of Vermont, this was done with over $800,000 that has been set aside for the allocation allocated to be used for contingency management. And then another option is to use state funds, which is also currently being done in Washington State and then in Montana. And then another option that Dr. Levine was talking about this morning is the ability to be able to submit an 1115 waiver to CMS to allow for CMS funds to be used for contingency management. And then finally, there are different options through different types of foundational grants and whatnot. In addition, there really is not a one-size-fits-all when it comes to creating an evidence-based contingency management protocol. So for example, decision makers and stakeholders that are going to be involved in this process do have to decide on numerous protocol parameters. And so a first question might be, well, what sort of CM protocol are we going to even be using? And so the two most common types that you'll come across are voucher-based and prize-based, or you might be referred to as a fishbowl method. And both of these are evidence-based with strong empirical support. The main difference between the two being that a prize-based is introducing a variable of probabilities, where a voucher base is typically conducted on a predetermined schedule of escalating incentive values. Then for things like duration, much of the research that's established the efficacy of contingency management has used 12 weeks as the length of randomized trials. However, a body of research does indicate that the longer the intervention is implemented will lead to more robust outcomes. And then another key parameter is deciding on observable and measurable target behavior. So examples of common target behaviors include things like stimulant negative urine samples in this case, with results that can be made immediately available. So through testing measures like point of care tests. And then relatedly, a decision must also be made on what the urinalysis target is. So are we targeting only the use of stimulants? Is it the use of stimulants and other sorts of substances? And the literature there points to if we can directly identify one target behavior, it's going to lead to the most robust outcomes. And if polysubstance use is being targeted, then incentive amount might need to be changed or adjusted to account for that. And then for magnitude, really this is looking at an optimal reinforcer amount somewhere in the 200 to 300 for every 4-week period. Frequency, more is the better, and really the ideal setting is somewhere 3 times a week, though twice a week schedule can provide a good assessment of stimulant use if those testing opportunities are being properly spaced. So say it's on a Monday or Thursday schedule or a Tuesday, Friday, as long as we're trying to capture behavior across the entire week period, 2 weeks or 2 times a week can also be used. And then last piece is the decision on whether or not to use escalation and reset, which is a component to effective contingency management. And then last, it may come up whether or not CM should be used as a standalone treatment or in combination with other sorts of treatments, kind of like Kelly was talking about with other sorts of treatments there. And then I did want to note that this list is by no means exhaustive of the different parameters that go into creating an effective CM protocol. Just a couple key highlights, and I could talk about it for days, but we will wrap it up there. So that is all I have. I don't think we have time for questions, but I appreciate your time, and thanks for letting me talk.
Thank you, Tyler. So let's please join me in giving a hand to the entire panel just there. Yeah. They did a great job.